I don't have any candy.
We don't want it. Look, she looking for
Peppermint. Some peppermint prizes.
We have been eating on them all year. Literally. Finally got rid of the Jolly Ranchers.
It's a burrito. I eat anything.
Get off of there. Go away.
I ain't saying nothing.
My baby. Yeah. She thought you said.
There we go.
I did not.
Yes, you did.
Good morning. Good morning, Malvern.
What's happening? Chapter 11.
No, I need 11.
Oh, girl.
Good morning, Malvern. Can y'all hear me?
No.
Yes, ma'am. I can hear you. Good morning.
Good morning.
What I need.
Okay, so everybody, y'all put up everything. Put up your phones and things.
She can't go over the test.
If the the couple of you that did not take the test, take a break for about 10 minutes.
Peace out, Bye, Michaela. Lucy, I love you.
Oh, hold on.
Oh, my goodness.
Let me take it off where they can't see either. Hold on.
Did you say when?
I'm saying with my
No, I'm talking about
homework,
her.
I need like 20 something. And then in the other class, I need like 11.
Oh, you had to
Well,
now? Yeah. I didn't bring my car on. I woke up like.
Oh, you was
right.
right.
I forgot how many I need. I need like 6. My neck a little sore. Without the homework facility? Without homework.
You said week or whatever.
Without.
Okay, can y'all still hear me?
It's like 50. But we got what?
Yes, we can hear you.
Okay. Okay, let's look at this test. Okay, that one looks good. Remember, we look at these average scores here to see if they are greater than 1, because that would be over 50% if it is. So over 50% of you got that one right. We're not going to look at that one. There we go. Yeah, now y'all are supposed to see. Okay, so this very first one, everybody did very well on that one. That one also, right lower quadrant pain with appendicitis with rebound pain.
No, I'm
Right?
trying to share the video so she can see our classroom. And it won't let me.
Can they see my screen?
Yeah, they can see your screen.
It's too small.
But it's small, they say.
Oh, I can't fix it from here. Okay. Let's keep going. Okay. That one looks good. Ooh, this one, y'all did really good on that one. Jaundice is caused by the liver because it's not able to fully process bile. Did good on that. Ooh.
That ain't good.
Ooh.
Don't look like.
I'm just sit back.
Lord. Okay, McBurney's point. Where is that? Number 1. Appendicitis starts at the umbilicus and then it moves down to the right lower quadrant, way down here. McBurney's point is where you're going to feel the most intense pain. It's going to be rebound pain. You're going to push it. There's not going to be pain when you push. There's going to be pain when you let go. Oh.
Let's go.
I got that one wrong.
The nurse is caring for a client with a broken tibia. Which of the following interventions should be performed first?
Cause I'm doing right.
It was that one.
You're right.
Yeah,
That's what I put red too. Cause I was like, cause it says first. So that's
Which
okay.
will you do first? Which one is the most important thing when you have a broken tibia?
First. And then we was called rice.
Yeah.
So
that's true.
That-
That's true.
Oh, yeah. That's what I put red to.
Yeah, don't give us our point back.
Elevate the extremity.
Because before it's a rice, it's land.
Elevate the extremity. If you have a broken something, usually your leg, you want to elevate that extremity, even your arm, but you're going to get compression syndrome in your legs usually.
So why not apply compression to the extremity?
Because elevation is the way to prevent compression syndrome.
Okay.
That is the first way to prevent that. We'll look at that. Obviously, nobody knew that answer except 29% of you. Uh-oh.
Okay.
The nurse is collecting data for a 15-year-old being seen in the clinic for a head injury after a football accident. Which question will the nurse ask first?
Did you lose conscious? That's what I got.
I put, did you, I should have picked something else.
Yeah, you should have picked this one because that's the most important. Then you can say, well, were you using a helmet? Because if they were using a helmet and they lost consciousness and they have a concussion, then we need to trash the helmet. Water don't have anything to do about it. And this, using your phone and your whatever, that's just afterwards, after the fact. So it decreases that stimulation to your brain. We'll look at that. Now, it will be Friday before I get to go back and look at tests. I've got clinicals tomorrow and Thursday. I know there's been a couple of them.
Okay.
All right, you select all that applies. Remember, even though this number may be low, we're going to look at the percent correct on these and make sure they're above 50. So everybody scored over 50% on those. A head injury.
I got them mixed up.
What's going to happen with the blood pressure in head injuries? It'll increase. Yep. Yeah, for increased intracranial pressure, heart rate increases, blood pressure increases. That one looks good.
I didn't put the encouraged periods on the check.
I got that one.
Yes, they need some loving, so they need to be held just like any other baby, and they can do that.
I got that right too.
Percent correct. Yeah. Bucks traction.
Yeah, I put the head.
Okay. Bucks traction. The heels of the feet are touching the end of the bed. Why would that require intervention?
Pressure on the heel.
It's pressure on the heels. It's not providing any traction if the body's up against the footboard and the weights are touching the floor. Why?
So how's the head? What's the degree for the head of the bed?
It's supposed to be flat. Yeah, they're supposed to be flat.
So why not? Why, I mean.
So why would not be
Right, selected.
Why would it not be?
because if they wouldn't it require an intervention?
Oh, I see. Gotcha. Okay. Okay.
It's gonna be that one.
Oh.
I see where y'all are going. I see what it is. Okay, y'all did really super good on that one.
Cause I know if no 5-month-old say
Say
ouch.
ouch. Yeah.
It definitely can't point to no ear.
Neurovascular checks. Y'all did very good on those. Phototherapy. What's phototherapy?
Like when they have, like when you put them under the light.
Mhm. Under the light.
One of those,
So
I didn't put report intake and output.
I put report and taking out.
I did, that's how I missed it.
why do we need to do intake and output?
I didn't put the finger. So because messing with their liver and it or kidneys or something?
No, but we need to know exactly if they're pooping or peeing, because that's the way to get rid of the jaundice is pooping.
Oh,
And if they have a IV, if they're getting an IV up here with this hydration, which we don't always do an IV, it's very seldom that we do an IV with jaundice anymore. We just bottle feed them or breastfeed them, whatever they're doing, and they get adequate hydration through that. So we don't hardly ever use an IV, but we need to always make sure we're doing intake and output so that we know that that baby is pooping and peeing. Apply eye protection. Everybody got that one right. And remove eye protection when the baby is feeding so they can open their eyes and see. Ooh, that was close though. Why would you not take off their eye protection when they're out feeding?
I didn't think about it.
You were just
I was
thinking about,
you leave them in there and just give them their bottle while they eat.
Yeah, that's what I was thinking.
sometimes you do.
I mean, we've seen it, I remember looking at the.
well, just
we
go
saw-
look at it.
Because that is close, we'll think about it.
And a few minutes ago,
Yeah.
and the mom was feeding the baby was still under the
Yes,
light.
it was in the book.
Yeah,
Yeah, that was in the book, wasn't
yeah,
it?
don't give us that. Got that one right.
Those all look good. This looks good. This looks good. Good.
Y'all ain't do this good on the test. No,
I
let me
did
stop.
really good.
Okay, so don't do it, come on, let's move it on.
Need to get off of here.
She at least said 3, they gonna do that.
Only
Get
got
off
2
of
of
there.
them though, but I'm back in the 70s. I can make a 70 something.
You can do it. You can do it. Okay. We are ready to start Unit 7, our very last unit. I know. I am feeling that. I am feeling that. It's been a long semester. But when you look back at it, it's gonna be like, man, that was really fast.
It really was sad. but-
You will.
It's been a little rocky. I think just life period, being in nursing school. I don't think nursing school is so hard. It's just life outside of it. So it was not.
That's your
really
always
the worst
nursing
for
school
me.
in high school.
Yeah, that kind of stuff.
In high school.
Not on this.
It's happening. They're doing LPN school in high school and they're testing it, so it's only sporadically.
That's scary, honestly.
Honestly, that is
When I was a
correct.
teenager,
But y'all gotta think about these teenagers way more advanced than what we was.
I can't imagine myself. I don't know, I was pretty mature.
But think about like 17-year-olds now.
Oh,
They like creating shows and millionaires now, like.
mhm.
17 when she scared me.
All right. Can y'all hear me and see me? See the PowerPoint, Malvern?
I'm like,
You got it?
no.
Down there?
Yes, we can hear you.
All right. Chapter 25, respiratory disorders. Okay. Respiratory stuff starts on page 593. It is basically the same thing as adult respiratory stuff, except that when a child is in respiratory distress, their cardiovascular system cannot compensate for that respiratory distress, and they are at risk for crashing because of respiratory stuff. Where we as adults, I can have an asthma attack and I will be okay. Kids may get an asthma attack and crash because their cardiovascular system, their heart, cannot withstand, it cannot compensate for the lungs. Okay? That's pretty much the only difference, the most important difference between kids and adults. So if you have a kid that's really, really working hard to breathe, maybe got pneumonia, having an asthma attack, you need to have a crash cart close by. Okay? All right. The respiratory system, respiratory rates in children are higher than adults, and we already know that. What's your respiratory rate for a baby, like a newborn baby?
130.
So don't worry about it.
And it's 20 to 30 or something? Or 30 to
We're getting closer. Respirations. 30 to 60. 30 to 60. Now, a couple of weeks ago, we saw a baby that was super sick that we sent out to Children's that was breathing 130 times a minute. So 30 to 60, I'm not going to ask you all the rates, all the vitals for kids in the different ages, but you do need to know that babies' regular respiratory rate is 30 to 60. And then it just goes, it decreases with age. Okay. Abdominal breathing is common in infants. They're belly breathers. When we're counting their respirations, it's really easy for us to look at their bellies and watch how many times they breathe in their belly area. Oxygen consumption is high, and their metabolic rate is higher than in adults. They're burning a lot of calories just being alive. Their airway diameter is smaller. That makes sense. They're smaller, so their airways are going to be smaller, so that puts them at higher risk for obstructions with something they put in their mouth or just with secretions and snot and stuff from a cold. Mucous membranes of airways are highly vascular, and they are susceptible to trauma, swelling, and spasm. Surfactant. Remember we talked about surfactant in preterm babies? We don't have it in the preterm babies. They start making it about 36 weeks-ish inside of mom. So if they're born prematurely, they don't have that surfactant, and that surfactant is real slick, and it opens up those airways and keeps them from sticking together. Whenever the babies are born and they take their first breath, that surfactant slickens up those airways, those little alveoli, so they can puff up and take in oxygen. If they don't have surfactant, like in preemies, then those airways just stick together. They're really sticky. So that's something that you have to remember. Surfactant. Preemies do not have surfactant, so when they're born, we have to give it to them, and we give it to them down an endotracheal tube. Accessory muscles of respirations are not as strong in children, particularly in infants. That's why they get into some distress. What are your accessory muscles? These neck muscles, yeah. You'll see them really tugging as big kids, but as babies, they don't have that. They're not that strong. Chest wall retractions are common in infants with respiratory problems because the chest wall is supple or soft. Those ribs, they haven't ossified yet. They're not hard yet. So everything sucks in when those babies are trying to breathe. You see those retractions when they're having a hard time breathing. When you see retractions up here in this supraclavicular notch, this little notch right here on top of your sternum, that's going to be an upper respiratory problem. When you see retractions down here in your ribs, that's a lower respiratory. What else might you see in a baby with respiratory distress?
Flaring nose.
Yes, flaring nose. Have y'all seen that? Has anybody seen it? Their little nostrils just every time they take a breath in. All right, ventilation. We all know what ventilation is. That is the process of breathing air into and out of the lungs. That is respiration. Ventilation is respiration. It's affected by several elements and their interaction with each other. So the muscles, your rib muscles, your intercostal muscles, your diaphragm down here in your belly that separates your chest cavity from your abdominal cavity. That's a huge muscle. And without that muscle, we're not going to be able to move our lungs up and down, move that air in and out. The ribs allow chest expansion and contraction. The brain has an important part in respiration because of that. The brain is signaled by the central nervous system throughout the body to breathe. The brain isn't just saying, okay, breathe. It's got to have that signal from our lungs to do it. And those little signals are called chemoreceptors. They're throughout the body, and they respond to changes in oxygen saturation in the blood. And that's what tells our brain, hey, we need to breathe a little more or a little less. Also, remember, in chronic lung conditions, the patient is tolerant to those lower oxygen levels. Remember things like COPD? They have learned, they've adapted to those lower oxygen levels in their body because they can't move air in and out very well anymore. They have very poor gas exchange in those alveoli. So they are okay with that lower oxygen level. So if we really wouldn't see it in a kid, but if we did have a kid with chronic lung disease or COPD, how much oxygen should be their max? Do you remember? 2 to 3 liters. Good. All right. So conditions of the respiratory system. Nasopharyngitis. What's that? It's a cold. It's just a cold. It's called acute, if you want to be fancy, acute coryza. It is the most common infection of the respiratory tract for everyone. Nasopharyngitis. It is caused by a virus called the rhinovirus. So if you go to Children's or wherever, if you take your kid to Children's now, they didn't used to, but now with COVID and all that, they do swab, and they swab you for the entire panel of all the colds. You've got your rhinovirus, you've got this virus and that virus. Every single cold they're going to test you for. But nasopharyngitis is caused by rhinovirus. It is spread from one child to another through sneezing, coughing, and direct contact. Susceptibility depends on age and the state of nutrition and general health. So a cold that just makes me a little bit sick may make Kiara Ross a whole lot sick if she's compromised in any way. Signs and symptoms. Fever is common in children under 3 with a cold. You're going to see nasal discharge, irritability, a sore throat. Why would they have a sore throat with nasopharyngitis?
Coughing.
Probably breathing through their mouth, like with their mouth open.
Mouth breathing. What else? What else can cause sore throat with a cold? Drainage, yeah. When you wake up in the morning and your throat's super sore, but then throughout the day it gets better, that is caused by drainage or postnasal drip, cough, and general discomfort. You just don't feel good, and y'all know. Everybody's had a cold, you don't feel good. Complications. Complications from colds, bronchitis, and we'll talk about bronchitis in a little bit, but what is it? If you just broke down that word, what does bronchitis mean? Inflammation of the bronchi. Good. Pneumonitis. What about that? Inflammation of the lungs and ear infections. Why would a cold cause a child ear infections? Because of that drainage, and that drainage is kind of trapped in those ears and in that throat. It's not draining down properly, especially at nighttime. So it's very easy for them to get ear infections, not only because of that, but because of the physical, how that eardrum and ear canal is made in that little one's ear. Short, straight, very easy for germs to get in. When you have a cold, are you going to get antibiotics for that? No. What do you take for a cold?
NSAIDs.
You can take NSAIDs if you have some pain with it. Decongestants, antihistamines sometimes. That's more for allergies. Treatment, there's no cure. Relieve symptoms with rest. Make sure they're resting. Make sure you have that bulb syringe around for little ones, especially that can't blow their noses. You want to get that bulb syringe and suck out all those boogers. Put some saline spray in their nose, thin out those secretions, then put that bulb syringe in, and you'll get a whole lot more out. Adequate fluids. Make sure they're drinking enough. Prevent fever with ibuprofen or acetaminophen. Are you going to give them aspirin? No. Skin care of the nares related to drainage. That skin gets very sensitive right here in that nose area when you're wiping it all the time, and when you've got snot coming out of it. Those little noses get really chapped. You can put petroleum-based ointment on their noses. Anything to kind of protect it. If you have a child on oxygen, do you put petroleum-based? No. Why? It can cause a fire. Yes, petroleum-based ointments and oxygen. You cannot use those things together. It can spark a fire. Antibiotics for colds are not helpful. This is a virus. When you do teaching with parents, you need to make sure that you tell them how to read the labels and dose those medications appropriately for weight. And it will say on the label if your child weighs blah, 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 between 10 and 20 pounds, or if your kid is under 2, make sure you use those correct dosages. One of the best ways to help that inflammation is a humidifier. Put a humidifier out in the room. With a humidifier, though, what do you need to do to it? Clean that thing every day. People will run that same nasty humidifier water for days. It is growing germs. It is gross. So make sure you clean that thing every single day and refill it with water. Hot water, steam from faucets in the shower can relieve stuffiness. So just go in the bathroom, turn the hot water all the way on, and just let that steam fill up the bathroom. Sit on the side of the bathtub and let that kid suck in that hot air. It feels good, and it opens up their nasal passages. These are the differences between a cold and allergies. With a cold, you're going to have fever, possible. Are you going to have fever with allergies? Does anybody have fever today? Does everybody have allergies? Just about, with this pollen everywhere. Just about. Purulent nasal drainage. So what does that mean? Snot, green stuff coming out of their nose. With allergies, it's just clear. It's not going to be any kind of infection in it. Red and mucous membranes with a cold. Those mucous membranes get inflamed. Allergies, you're going to have watery eyes and itching of the skin. Acute pharyngitis. What is that? It can be caused by strep throat. Yes, it is inflammation of the pharynx, the back of the throat. Inflammation of the throat structures. Signs and symptoms. We're not feeling good. Fever, malaise, dysphagia. What's dysphagia? Difficulty swallowing and anorexia. They get anorexia where they just don't want to eat because their throat hurts. They don't want to swallow. Viral pharyngitis. You'll see conjunctivitis. What is that?
Pink eye.
Pink eye. Rhinitis. What's that? Nose. Inflammation of the nose. Where am I? Cough, hoarseness with gradual onset, and it persists no more than 5 days. So your viral pharyngitis is not going to last more than 5 days. You're probably not going to have fever. Your bacterial characteristics. You're going to have fever with this. What is your bacterial pharyngitis? Strep. You have fever, difficulty swallowing, and it's going to last more than a week, especially if it's not treated. If we have strep throat, if we suspect strep throat, we need to have that treated immediately because it can lead to all other different things that are bad. Treat promptly to prevent rheumatic fever, glomerulonephritis, peritonsillar abscesses, ear infections, mastoiditis. What's mastoiditis? Mastoiditis. The bone infection. You've got this infection in your mouth that you haven't treated, and it's going to seep into your bones if you don't get some medicine for that. Meningitis, osteomyelitis, same thing, or pneumonia. Why would you have pneumonia from strep throat? You're swallowing all that nasty stuff and get it down there in your lungs. No longer infectious after antibiotic therapy has begun and fever has decreased. So 24 hours after therapy, after antibiotics have started, that child is no longer contagious and they can go back to school as long as they don't have fever. It's usually treated with penicillin. What kind of teaching are we going to do with our parents about antibiotics? Take the whole thing. So Billy's taking his antibiotic for strep throat. In 2 days, his strep throat feels better. Does mom stop giving his medicine? No. Keep going. If an older child, you can tell them to gargle salt water to help soothe that throat, and Tylenol is good to take pain away. If there's fever, you can also use ibuprofen for pain and fever. Croup. Who's had croupy kids before? None of y'all have had a croupy child?
Probably did.
It's a barky. They bark. They sound like a seal. They get a cold, a real bad cold, and then they start coughing, and it sounds like a seal bark. We'll listen to it here in a minute. Croup is caused by swelling in this airway, and that barking sound comes from that air escaping, and that's all that's squeaking by in that swollen airway. So it makes that sound, that barking sound. It's, what's the word? Like if you hear it, sorry guys, if you hear croup, you will always know croup once you hear it. It can develop into a respiratory emergency. Why?
Lose oxygen.
They lose oxygen, but why would they lose oxygen? The airway is swollen. Yeah. Treatment. Yeah. Treatment, increase humidity with cold water humidifier. So get that humidifier. If you don't have a humidifier and you've got a croupy kid, open your freezer and literally stick them, their head, their face into that freezer to breathe in that cold air. And it'll open up, it'll take that swelling down. The ice takes down swelling. It takes down swelling inside your airway as well. Hot water in a shower can help relieve those symptoms. They may need IV fluids, not usually, but maybe. Monitor heart rate, respiratory rate, and pulse ox. If you have to go to the hospital or to the doctor because of croup, they will probably give that child some steroids and maybe some racemic epinephrine, and y'all don't have to know the racemic epi, but that is used to take all that swelling out of the airway really quickly. If they get that, they have to stay in the hospital overnight. But you do need to know that they give steroids for croup. Why steroids? What do steroids do? Open it up, take away that inflammation inside that airway. And it's pretty instant when they get those things. Okay, they may start an IV and give an IV push of prednisone or dexamethasone, some sort of steroid like that, and it just opens up that airway pretty quickly. Just see if we can listen to this creepy. Oops, I think I just.
There are 3 simple changes I tell all my arthritis patients to make. Number 1, you have to start drinking more water. You wouldn't believe how dehydrated most people are. Number 2, you need to make a decision to take matters into your own hands. That's not to say you should go against your current doctors, but you don't have to settle for a cat.
Okay, let's listen to this sweet girl. See, you can kind of see she's retracted right here because it's upper airway. The airway is getting swollen and blocking off. She's also got some intercostal retractions. Barely see them because she's really working hard to breathe. She's really working hard to get that air down past that swelling. This child needs to go to the hospital if she's not already there. Let's zip her back.
Oh, yeah.
That
Yeah.
high-pitched cough. I know it's sad. It's hard on them. That's croup. They look very sick. They're very sick for a little bit until you get them some medicine and get that swelling out. Once you get that swelling gone, they're okay. It is the swelling in their airway that's causing all the problems. Okay, you hear that? That's wheezing. That's stridor also coming up. That's all the noise that's squeaking by that trachea. What are they doing for her? Anyway, let's get off of there before I stress out about it. Didn't look like they were doing a whole lot. So croup is okay until you get that. That is an emergency. It can turn into emergency. It is not always an emergency, but if you have a croupy kid and you have that seal bark cough, you need to go to the doctor and see if you need any medicine for it. You can also put them in the freezer. Don't sit your baby inside the freezer and shut the door. Just put their face in the freezer and let that cold frost come up into their face and let them breathe it in, okay? Don't put your baby in the freezer. Opiates are contraindicated in croup. Why do we do that? Oh, yes, respiratory depression. What about steroids? Every time it seems like a kid gets a respiratory problem, we doctors prescribe steroids. What about steroids for kids? What does that do to them if they're on long-term steroids?
I like build their immune system.
It causes them.
It decreases their immune system.
Oh, it decreases.
Decreases that. What else can it do?
Cause hyperglycemia.
It can do that. Yep. Steroids do that. What else? No.
Fluid, if it's fluid.
No.
So it's weight gain, right?
It can. It can. It stunts their growth.
Okay.
It stunts their growth. If they are on long-term steroid, overuse of steroids in children can stunt their growth. Let's see. Croup can also, it can be this that's acute from a cold, or it can be benign. Benign means that there's something causing it structurally. A floppy airway. That child has been born with something wrong in the airway. It's just floppy, so they make that sound sometimes just random.
Yeah,
Here and there.
breathe, like heavy like that.
Mhm. Yeah, so it can be caused by a structural problem like laryngomalacia. That's what it's called, floppy airway. So anytime that floppy airway gets complicated with some swelling and it's already a floppy airway, then we're probably going to see an emergency in that kid. What kind of kids do you think have laryngomalacia? We talked about on last unit. A certain kid, Down syndrome. Yeah, Down syndrome, because they don't have any muscle tone. So that everything is floppy in a kid with Down syndrome. So their airway is floppy as well. They will grow out of it, hopefully, as their muscles build in their body and that airway gets strengthened with time. Epiglottitis. Y'all need to inflamed epiglottis. So where's your epiglottis at? It's that flap in your throat that separates your trachea from your esophagus to help prevent aspiration of food and things into your lungs. So it's just like you've got, okay, your airway right here, your vocal cords. See that V? That's your vocal cords. This little hood thing right here is your epiglottis. That is normal. When it gets swollen and irritated in epiglottitis, look at it. What's happened? It clovered that whole airway. Can that kid breathe? No. What's this? That's a breathing tube, yeah. So that kid had to be intubated. This is a medical emergency. Swelling of the tissues above the vocal cords, narrowing of the airway inlet, possible obstruction, possible total obstruction from that swollen tissue. It can occur in any season. Anything that causes any kind of viral, bacterial, anything can cause this. Its major cause is influenza. It's caused by the flu, mostly. Remember, it is life-threatening When that epiglottis swells up over that airway, over those vocal cords, we cannot move air in and out. Signs and symptoms are abrupt. These kids, they naturally insist on sitting in a tripod position. What's a tripod position? Yeah, sitting up. They're sitting up crisscross applesauce-ish on the floor, but they are leaning forward. They've got their hands in front of them, leaning forward. That neck is stretched out so that they can get as much air in as possible. That's a huge sign and symptom of epiglottitis is tripod positioning. They will also start drooling. You'll have a kid that don't drool, and they'll all of a sudden start drooling. Why would they drool? Why would that happen in this condition?
Maybe they got their mouth open.
Because the throat closed, so they can't swallow right.
Throat's closed, so they cannot swallow. That is right. Good job. Their throat is closed. They're still making secretions in their mouth, but they can't swallow them, so they've got to come out some way. So they'll start pouring saliva out of their mouth in the tripod position. Difficulty swallowing. They are wide-eyed, anxious, and restless. If you can't breathe, how are you going to act? Wide-eyed, anxious, and restless. Cough is absent. That's another huge thing. They cannot cough. Why can't they cough? No. Act like there's not a tube. It's swollen. It's closed. Those vocal cords are closed. You can't get air past the vocal cords. What makes our sound is that air going into our throat and vibrating those vocal cords. If they're covered up, you can't make any noise. They may have a frog-like croaking sound on inspiration. Their throat shows enlarged, reddened, edematous epiglottis. That looks like a beefy red thumb. Kind of, I guess. When you see these kids, if you see these signs and symptoms on a child, do not stick a tongue blade inside their mouth. That can lead to a bronchospasm, and we're just making everything worse. So do not put a tongue blade in their mouth, or laryngospasm, I'm sorry. Laryngospasm. Now we're just adding on to that airway being closed off. We have to have a trach kit at the bedside. That doctor may have to do a tracheotomy on that kid right there at the bedside to get air in. Okay, we are not using a tongue blade if we see signs and symptoms of tripod position, no cough, excessive drooling. Have your trach set at the bedside. Why are we doing a trach? Yeah, it's closed off. We're going to do that trach to make them a new airway. And it will not be permanent. They'll be able to go back to normal once all this swelling is done. But they have to breathe. And us getting an IV and all that is going to take time so that we can get the steroids in to take that swelling and inflammation out. They have to be able to breathe while we're doing all those things. So we're going to have to probably have a trach. So trach or intubation. The intubation is going to be very tricky with all that swelling. That little hole right there is very, very small. It looks big on this, but it's very, very small. And with that swelling, it's going to be even harder to find. So it's going to be easier to do your tracheotomy. There's just a little picture there about epiglottitis. Y'all hot in here? Just a little stuffy. It was freezing cold when we got in here.
Yeah, it's like almost first.
All right, so your epiglottitis has 4 Ds. Hold on, we're not there yet. Treatment, we already talked about it. Immediate tracheotomy or intubation, but trach is best, your fastest, best way to treat that so that we prevent hypoxia and sudden death due to respiratory distress, arrest. Remember, kids, they die because of respiratory stuff, not cardiac. I mean, they can die of cardiac stuff, but once they get so compromised in their respiratory, they just can't compensate with their heart. Antibiotic therapy usually results in dramatic improvement within a few days. Prevention of epiglottitis is the flu vaccine. It is caused by the flu. To prevent epiglottitis, get your flu vaccine. Get your kids your flu vaccine.
So the book says beginning at 2 months, but I thought they couldn't get the flu until
The flu
the
vaccine,
flu vaccine until 6.
maybe not. Maybe not. I actually think they cannot have the flu vaccine until they are 6 months. So if that is the case, they cannot have a flu vaccine until 6 months. So how would you protect that child? If it's your child, how would you protect that child from getting the flu? You get your vaccine, and your whole house gets your vaccine. Remember, it is your responsibility as the nurse to make sure you have a trach kit or an endotracheal tube set, an intubation set at the bedside for any mouth examination or throat. What time is it? Okay, this is a picture of tripod positioning. You see he's just sitting crisscross applesauce, but he's leaned forward with his neck stretched out. His mouth is open. That tongue is out because he's trying to get everything out of the way inside of his mouth to get air down. So 4Ds, dyspnea, difficulty breathing, stridor, nasal flaring, intercostal retractions, so retractions in between the ribs, tachypnea. What's tachypnea? Increased respiration, yeah. Tachycardia and cyanosis. Is it normal for a kid to be blue? No. No, 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 no. What about drooling? You're gonna see drooling, dysphonia, or difficulty speaking, and dysphagia, difficulty swallowing. In that tripod position. Bronchitis. What's bronchitis? Inflammation of the bronchi. Where's your bronchi?
It's in your lungs, ain't it?
Your lungs. How many bronchi do you have? 2. So you have your you have your trachea that comes straight down, and then your 2 branches that one goes to right, one goes to left. Those 2 branches are your bronchi. It's inflammation of the bronchi. It's usually secondary to a cold or a communicable disease. Poor nutrition, allergies, and chronic infection also increase that risk of bronchitis. So you get a cold and you just don't get better, then your chest starts burning and coughing, and now you're coughing up junk. You probably have bronchitis. Signs and symptoms, gradual onset. It takes a minute. You just don't wake up in the morning and have bronchitis. Gradual onset of unproductive hacking cough preceded by upper respiratory infection or a cold. The cough may become productive with purulent sputum. So once you get sick enough, you're going to start coughing up some stuff, and it's going to be stinky. Purulent green, brownish color sputum. Treatment. We can tell parents to give them cough suppressants before bed. Help increase rest. Tell them to rest. Antihistamines are good to open up everything. Expectorants. What's an expectorant? Helps you cough it up. It thins it and helps you cough it up. What is do y'all know an expectorant? Mucinex. But what's in the Mucinex? That's guaifenesin. Yeah. Guaifenesin is the expectorant. It is in the medication. Antihistamines. What's an antihistamine? Benadryl, Zyrtec, Claritin, all those things. Antibiotics are not usually helpful. Most children recover uneventfully at home. Bronchiolitis, not bronchitis, bronchiolitis. Where's your bronchioles? They are attached, those little tiny tubes attached to your bronchi. And those little tubes lead to the bunches of grapes, your alveoli, at the end of those bronchioles. So bronchiolitis is an infection of those small airways, the bronchioles, in the lower respiratory tract, down inside the lungs. They get obstructed because of inflammation, swelling, excess mucus, and all of that. That excess mucus can lead to atelectasis. What's atelectasis? A collapsed lung, where those little alveoli just collapse because they are swollen and they're full of junk. They just give out. They collapse. That causes, what does that cause? If your alveoli don't work, what's not happening?
Gas exchange.
Gas exchange, yeah. So bronchiolitis leads to impaired gas exchange. It is usually caused by RSV, respiratory syncytial virus. Have y'all seen a baby with RSV before? Has anybody's babies have RSV? Yes. It is common. It usually happens in the wintertime. Last year, we had a huge outbreak in the summertime. And I think it was because everybody kept their kids in the house and they didn't go to school, so nobody got exposed to anything. And then when summertime came, wham, the RSV hit. And a lot of kids got in the hospital in the summertime from RSV, usually in the wintertime. Signs and symptoms are going to be the same thing as any other cold. It's just a cold. Upper respiratory infection or a cold with mild fever. You'll see clear nasal discharge, a wheezing cough, and then signs of respiratory distress. So it gets very serious for these littles. We, as adults, can be carrying it around as carriers of RSV. It doesn't bother us. We might get a little cold. Our school-age children, they may have a cold. It doesn't bother them. But when these babies get it, it really bothers them. Not all of them, some of them. An increase in respiratory rate interferes with feeding. They can't feed well because they can't breathe. They're trying to breathe really fast, so they can't latch on to a nipple and eat. The infant becomes irritable and dehydrated. Do they become dehydrated quickly, or does it take a long time? It's fast, yeah. It's really fast. Apnea is common. How long do you have to stop breathing to have apnea? 20 seconds. It usually causes hospitalization. These kids may develop hyperreactive airway or asthma later in life. So with your treatment, you're going to put these kids in semi-Fowler's position. They will get IV fluids because they can't eat because they're breathing so fast. If you do IV fluids, you have to monitor what? Output, ins and out. Yep, intake and output. So if you're giving IV fluids, monitor eyes and nose. How do we monitor output in a little baby? Diaper. We're going to weigh that diaper. We'll take a dry diaper and weigh it, and then we'll take the wet diaper and weigh it, and the difference is the output for that baby. High humidity tents. Those were things back in the old days, in the 2000s, the early 2000s, 1990s, those times back in the old days. I have never used a humidity tent ever. I feel like they're gross. That kid is going to be wet from all that humidity. It's like those mist tents at the fair or whatever in the summertime. Bronchodilators. What is a bronchodilator? What type? Yeah, like albuterol. Bronchodilator. It's open up those bronchioles to get that air and gas exchange going. Frequently assess vital signs and O2 saturations. These kids will be on a pulse ox continuously. Monitor them very closely because they are sick. If they're sick enough to come in the hospital with RSV, they're pretty sick. They're usually there a couple of days with this. Okay. So how do we give a bronchodilator to a baby? How do we do that? You use a mask. You can, this little spacer, I don't have a mask with it anymore, but we can use this, or they will more than likely come with an updraft machine. They'll put the updraft mask on and just updraft that baby with albuterol. Okay, so RSV is the most common cause of viral pneumonia, especially in little ones, especially in infants. It is spread through direct contact with respiratory secretions. It contaminates it's contaminated hands to eyes, mouth, or nose. So kid touches something, puts his hands in his mouth, his eyes, picking nose. That is how they get RSV. It survives for more than 6 hours on countertops, tissues, and soap bars. So what type of isolation are you going to use with RSV? Contact, because it is on things. If you touch things, you can bring it with you. So you're going to wear what? Gown, gloves, mask. You can wear your goggles if you want to. I want to make sure it says that in the book, because I feel like it said something different. But RSV is contact isolation. Okay, contact. Signs and symptoms are going to have thick mucus, wheezing, and respiratory distress. They're sick. They will probably have fever. Treatment: antivirals, mist tent, symptomatic care. We are basically going to treat the symptoms. If they have a lot of wheezing, we're going to do updrafts or bronchodilators. We may even give steroids to take that swelling out. Nursing care: monitor vital signs, wheezing, rales, rhonchi, and O2 sats. If you've got a kid that has been wheezing and breathing real noisy, a lot of noisy respirations, and then they don't, that is a sign of respiratory arrest. They have stopped breathing, they have a quiet chest, they've been rattling for 12 hours, and now all of a sudden they're silent breathers. They're going into respiratory arrest. If they go into respiratory arrest, what's going to happen? They're going to crash. Yeah, they're going to crash. So make sure that you have that crash cart. Suction them frequently. They're going to be very snotty. They're going to have a lot of secretions, and you're going to have to deep suction these kids. Monitor I's and O's. Remember, reactive airway disease later in life, and they will become more sensitive to the environment. Environmental irritants like pollen, dust, dander, those kinds of things in your house. Okay, let's take a break. Let's come back at 9:10. Huh? Yeah. Let's come back at 10:50. No, let's come back at 10:45. 10:45.
It works.
Which one? Isn't it North Central? No, it's you got a dark one. Gotta go get it. I'm not. What I gotta do with the throat. Just keep it. Pull it out. I'm almost. I feel so bad, though. Like, I don't mean to. Yep. I really don't. She's a good lecturer. It's just hard to sit here.
Yeah, it's just hard to sit.
I told her that the other day. I was like, listen, you were really good. I just have my own problems that I'm over here nodding. It's not nothing to do with me. Plus the room. The room got warm and I was over here like.
This is another problem down here is that these windows,
Yeah.
I like to see that I like them. Not like I can see out of them very well, but in the summertime it is blazing hot in here.
Yes. They created a little incubator. Ooh. These chairs
What time you think come back?
10:50.
Huh? Okay, I need it. Okay. Did you see what I was looking for? I mean, what I was telling you about? I said the money that was up in the thing. Okay, well, go ahead and pay for it. How much is the oil change? Okay. Where you go? Okay. I'm trying to see what I need to do. Oh, okay. Yeah, I mean, 'cause I ain't know, you know.
Oh, yeah.
Okay. All right.
You want them potatoes. Oh, yeah, I always a long chapter. God.
What type of food is this what we had for this type of? We on slide 18, we got 46 slides. You're saying you're supposed to have them all up next week.
Look, I had looked at your pictures because I was gonna do like the pretty skirt with the sweater. And I'm like, now I seen her pictures, I don't want to think I'm copying.
Randy
So
gonna say,
now I gotta come up with something else.
Randy gonna say, I ain't gonna lie, I'm still one of your poses where you sitting on your books.
I was gonna stand on my boots, like 1 foot on them.
I did that too.
Yeah, because that's just what most
Uh-huh.
people do. But I guess I'm gonna do a scrub. I was gonna order a cap and gown and do a black cap and gown, but
I wanted to
Oh,
do
man.
one, but I was like, don't seem like we in our capital.
it's just so much, just money you spend,
Yeah.
that's all.
It's a lot.
And then I was gonna do one in like this, you know how the blazer little dresses, like the black one I had for my father-in-law funeral, I was gonna do a white one, and then a white
I had
scrub.
one like, like, not example, but something that I thought about doing. I had went in and Googled a whole bunch of like graduation pictures.
So now
before
I gotta
figured
find me
out
one
my-
more. I'm like, I looked at him pictures.
She just, woo, nurse bag all the way. Okay, then. You posted? Cut that stomach right on off.
I take my pictures, Saturday.
Where you go?
Care Clay.
He in a shop down here?
He got a shop in Little Rock, but like he'll go wherever you want him to go.
That's how they.
I thought about going to the school, but I might just go to the shop cause
Cause
I don't know how I'm gonna be
one.
outside
Mhm.
sneezing.
Yup, I wanted to do one like coming down the stairs, you know, when
Mhm.
like you hold it
So
up
the
and
ass
you
is,
got
so
one
the
foot
time
walking
for
down.
sure.
But that man, you still gotta pay your base price, then he charged like
Of
72
traveling
cents a
fee.
mile. Then I was like, what if it started raining? What if my hair ain't doing right? I was
That's what
like,
I said too. I'm like,
I'ma save it for RN or whatever.
that's what I said. I'm like, my allergies ain't gonna let me be
Yeah.
outside too long, so
Yeah,
no.
you booking your pictures weeks in advance, so you don't really know weather change. You know, so I was like.
And then we supposed to have some bad weather this
All
week, so
week.
I don't know how the weekend gonna be. My scientist must have passed her in class.
She reposted her too.
She just said whoever counted me out can't count, and she posted a picture with her scrubs and stethoscope.
Yeah.
I really gotta stay woke. Oh my God. I need food.
Okay.
Yeah, I really be sleeping.
So I need to make a baby. Yeah.
Okay. And then she'll probably be giving questions back. So.
You gotta make a meeting here.
On the next day.
Did you add the end of course?
Miss Goss. Miss Goss. Miss Goss.
If she, right. If she like
Who is
playing,
that?
that's who it sound like, Michaela. Who? Cause she ain't really got no pictures on her Facebook, but you would know her. And then I got right to go to her hospital with this one.
Oh my God.
Like, we just need to, you know, her hospital, do we all be on the same floor? I don't remember.
You can go to
No.
OR, you can go to the floor, you can go to ER.
I ain't going to no GI lab.
You can go to cath lab.
I want to thank you. I love thank you.
I go to the OR. Or I go to the floor, I just don't want to be where she at.
When she asks, you be like the opposite.
I'm gonna wait till she say what she going. Not there.
The OR, you in a room though watching, ain't you? Okay. Yeah. You don't go.
You don't really do nothing in surgery. As the nurse, you just watch to make sure they ain't breaking sterile field and stuff.
Yeah. It ain't like Celine.
It's boring, but
At the heart
So like you
hospital?
can't go in the operating room?
At the heart hospital.
At the heart hospital, you can't.
and that's Celine you can.
And you don't have to change your scrubs at the heart hospital.
Unless joint commission goes. I like the heart hospital better surgery. Is the nurses
And
will
I
like
had
sit there
me
and
in the
talk to you.
window, like.
Cause what?
What that GI?
You said cause what?
The nurses will actually talk to you.
It was the
Oh.
operating room.
Yeah, I like the heart hospital. What floor?
I
was that,
like the heart
fifth floor?
hospital period, yeah.
At the heart hospital or second floor? It
Is
was
it-
second.
Yeah, we think it feels it's Celine.
Every time I go outside, I forget my pencils.
Girl.
I'm not falling asleep.
And cut the air room.
Oh, no.
Right.
I know they do.
It feel like it.
She's watching me.
No, she ain't.
She
She's
sleep
asleep.
No.
That's a golf trainer.
She finna be a teacher.
I mean, I know that, but I'm just saying, it ain't never. She sleep on the floor, so yeah, she was right where I said. I'm so
We were
tired.
just all year, you know.
Told you the next thing. I'm just tired. Where was the?
Last lecture, except for live. We on slide 18, we gotta go slide 45 to each chapter.
Do we have another one?
And then
Yeah.
the other chapter.
Yeah. It's only two.
Yeah, we're 100 slides.
It's 100 total.
I really,
I'm just saying.
really can't think about going home.
Yeah, I'm gonna have to leave at 12.
I don't think I can leave no more. I missed last Tuesday, my allergies was kicking my tail.
I think it's the only slide. It's the only PowerPoint.
It's only something.
It's two, it's 77 all together.
It's,
Which one?
cardiology got its own.
We on slide 17 on the first one, but it's only 46 on the first PowerPoint and 31 on the second PowerPoint.
Where y'all see the second slide?
It's like right above that blood
I
flow
don't
to the heart.
ain't got no slides on, but
Right
Oh,
where,
chapter
yeah.
26.
So she got a grade form.
let me see if she got a grade or not.
Let's go.
I think
thought I was talking to you.
Yeah.
She got a grade form and then mid remediation. Oh, somebody was in my
Somebody was looking for me?
Mm-hmm.
Who's looking for me? Did I? I don't think I closed off the
I
microphone.
gotta pay that charge. Charge us so fast.
They were charged. No, what happened? So next,
Yes, Miss Kathy. Yes.
Is the test for the next week?
Yes.
Okay, on Tuesday?
Yes.
Okay, it's on the syllabus twice, so we were just trying to make sure.
Oh, yeah, it's next week.
But everybody wants to argue with me, so I was.
Let me make sure that it is, and I'll let y'all know. But yes, it's next week.
She didn't say it, it's actually under our point. She redid it, yeah, she redid it, like.
Hold on.
The 19th.
It's there.
Hold on. Yeah, next week. That's next week.
Unit 7, it says 419, and then dosage care.
Is there a unit 7 assignment?
Yes, there is, and I will upload it
Okay.
later today.
Oh, I see what they saying. It say unit 7 exam 419, and then week 16, it say unit 7 exam with, Kaplan in the course exam.
Mm-hmm.
Yeah, I had those twice in my calendar,
Oh, 419. 419 is next Tuesday is your Unit 7 exam. Mm-hmm.
Could we see if we can do intercourse after that?
Just leave it how it is.
We already got to do intercourse.
Probably not. And this is why I'm going to say that there probably is somebody else testing sometime that day. Okay, so next week, Unit 7.
And then the week after that is the live review.
Yes.
Yeah, and then the week after that is, you got.
So the live review is 3 days, is 3 days the live review or 2?
I think it's 2 days.
So next Tuesday and Wednesday.
Let me get the schedule out. Let me get the schedule out.
It's on the 25th.
That is this week. That was last week.
The Kaplan exit exam will be 27. It's the 25th and 26th, Monday and Tuesday. The 27th is the lab quiz and the Kaplan exit exam. And those is care too, if you got to.
Let's see. I've got NCLEX Live Monday the 25th. NCLEX Live Tuesday the 26th. And then on the 27th, it says that y'all have Part 2 Med Lab Quiz. This is my teaching schedule, so it may have changed. But Kaplan is Monday and Tuesday. You have a Kaplan exit exam on the 27th. Do y'all have that on your calendar? That's what I got. Dosage Calc Exam 2 on the 27th as well.
I have to go through.
Oh, man. You got pneumonia. Okay, let's get started back. Pneumonia. On page 601 is where pneumonia starts. It is inflammation of the lungs and the little alveoli where the gas exchange occurs, where we switch our oxygen for our carbon dioxide, where all of that happens, gets filled with exudate or just snot and infection, pus, whatever, and surfactant inside those little sacs may be reduced. So everything's getting stickier and stickier. that portion of the lung that has pneumonia, it may be just in one little portion, or you may have pneumonia bilaterally on both sides, and you may have it in just one lobe on one side, or you may have it in all lobes on both sides. The affected portion of the lungs does not receive enough air. Breathing is shallow, and the bloodstream is denied sufficient oxygen because we're not having our gas exchange, so oxygen is not getting into our cells, so that's leading to what in the bloodstream? Hypoxemia, low oxygen in the blood, hypoxemia. Toddlers often aspirate small objects because they stick everything in their mouths. Peanuts, popcorn, Legos, Barbie shoes, whatever. They're going to stick it in their mouth and develop pneumonia as a result. So that stuff goes down into their airway, gets stuck in their lungs, and it builds up bacteria inside there. Early ambulation after surgery helps prevent pneumonia. So if we have anybody, adult or child, that has surgery, we want them up as soon as they can, as soon as they are able to safely get up and move around and walk. This is droplet isolation. Your book says airborne on 601. I think it does.
At the top, it does. Airborne infection isolation precautions recommended.
It is not airborne. It is droplet because we're spraying those droplets out whenever they cough. But Miss Remo did do her research, and she says the CDC says it is droplet. It is droplet. Pneumonia is droplet isolation. What are you going to wear in a room with a patient that has droplet isolation precautions? What kind of mask are we wearing for droplet? Just a plain surgical mask. Yep. A plain surgical mask for droplet isolation. Do we have to wear it as soon as we go in the room, or does it have to be within a certain, like 3 to 6 feet, something like that? I'm not going to test you over that, but just know that you don't have to wear it when you're standing at the doorway. But if you're going to get close to the patient, you need to wear your mask. If you're going to touch a patient, what do you need to wear? Gloves. Yep. So droplet isolation, surgical mask, and that's all you need. Signs and symptoms of dry cough that begins to gradually become productive, going to start coughing up stuff. They will have fever, increased and shallow respiratory rate. Why would they not be taking deep breaths with pneumonia? Why else? What does that stuff cause when you breathe, when you have pneumonia? Has anybody had pneumonia?
Exudate.
It hurts. It hurts. So whenever you take a big deep breath, it hurts really bad. So they compensate by taking more shallow breaths. Chest pain, sternal retractions. Where's your sternal retractions? Right here in the middle. So substernal and suprasternal. Flaring of the nostrils. You're getting into respiratory distress when you see those nostrils flaring. Why is, not only because of the junk that's in their lungs is painful, but why else would it be painful to have pneumonia? Yes, but why else?
Does that have to do with the diaphragm?
Partly, yes.
Since it's not expanding, like.
Yeah, kind of, but because they're not taking in oxygen. They're not getting the oxygen in at a cellular level, so it's not getting to their muscles. So their muscles just ache and hurt. Yep. Yep. That's why. That's why. Does that make sense? Oh, that makes sense. Treatment of pneumonia, it depends on the cause. Is it viral or is it bacterial? Antipyretics are given to reduce fever. What's an example of an antipyretic? Acetaminophen or Tylenol or ibuprofen and those things. Oxygen is administered for dyspnea or cyanosis. Want to increase their fluid intake. Why would we increase their fluid intake? Help thin it out so they can cough it up. Yeah. Give them flat, clear liquids. What does flat liquids mean?
Not carbonated.
Yeah, not carbonated. Yeah. Rest, cough suppressants before bedtime. When they are up and they really have a good sized pneumonia and they're up moving around, they're going to get short of breath really easily. So they need to be up moving around, but they also need to have a fine line between moving around too much, getting too much exercise. They need to rest. Stress importance of rest. Planned quiet activities best support healing. So are we going to go outside and jump on the trampoline? No, we're probably going to do a puzzle or color, something like that in the room, Nintendo or whatever they do these days. Check vital signs regularly. These kids need to be on a pulse ox continuously. If anybody's on oxygen, they need to have a continuous pulse ox. For fever, if your child is burning up with fever, what do you need to do? Tylenol. What would be, okay, if you're not using a medicine, if you don't want to use a medicine, what should you do first?
Cool towel.
You can do that. Cool, tepid bath. Take those clothes off. Strip them down. Take off their blankets, a cool towel, put a cool washcloth on their forehead, and encourage fluids. If you've got a kid that don't want to drink water, give them Pedialyte. Freeze up that Pedialyte, make it popsicles. They like that. See page 602 and 603 for care plan for pneumonia. Amoxicillin is, what kind of medicine is that? Antibiotic is the drug of choice for children up to 5. If you're going to give a cough medicine before bed, a cough syrup, if you're going to give a cough syrup, how do you give cough syrup or how do you not give cough syrup? Yeah. Yes, Shaniqua. No water afterwards. Why? When you take that cough syrup, you know it just makes you want to shiver when you take it. I can't stand it. But when you take it, what is it for? What is its purpose?
To coat the throat.
To coat the throat. So if you drink water afterwards, what are you doing? You're washing it all away, and it does no good. Good. So remember that. Guaifenesin, we talked about that. That is a thinner. It thins out all that junk in there so that they can cough it up. It's an expectorant. I don't know. I'm just talking. Oh, wait. Yes. I'm just talking. I'm just talking off the top of my head. Just some notes I wrote down. So you have your cough medicines, and you see the one that says DM. What does the DM mean? Do y'all know that one? I always think it is diabetes mellitus, but it isn't. It's dextromethorphan. That is your Robitussin, things like that. So if it has DM in it, it has dextromethorphan. But if you want an expectorant, you have to look on the label and look for with expectorant, and it should say guaifenesin. No, methorphan. It may be in the book. METHORPHAN.
Is A-N?
Like orphan, yeah. So y'all need to know your differences in your oscillations. Contact, airborne, and droplet.
So far, we only went over 2, right?
Mhm.
Contact
And droplet, we went over droplet.
Droplet was with. I put on the goggles of the blood. Droplet with pneumonia, contact RSV. Okay.
So with droplet, you need to wear surgical mask. If you're going to touch a patient, you need to wear gloves. If the patient is going out somewhere out into the hospital, they need to put a mask on to protect others from getting sick. When we go into their room, we're protecting ourselves. Whenever they go out into the hospital, they've got to wear their mask so other people don't get sick. Airborne oscillation. What are you using for airborne oscillation? An N95 respirator. Yes. N95. That's the biggest difference. There's only a few things that require airborne oscillation. Measles, TB. One more.
COVID.
Well, okay, 2 more. COVID and varicella, chickenpox.
Oh, yeah.
Yep. So 4 things. 1 is questionable. We don't really know. Measles, TB, varicella. Those are the 3 that are in your book somewhere. You need to wear N95 respirator. They'll be in a negative pressure room. So their room, their ventilation system goes straight outside to the hospital, to the outside air.
So, C-diff, that would be droplet.
That is contact. Yes, C. diff is contact. We do not want to be touching anything with that. So that's gown, gloves. Yeah, you don't forget that, do you? Your MRSAs, your boils and things like that, those are going to be contact oscillation. So this is just a picture about pneumonia. In normal lungs, this is our air sacs, our alveoli, clear. They don't have any stuff in them. That gas exchange can happen across these membranes where we can breathe. When you have pneumonia, your alveoli, they're filled with pus and blood, who knows what, all in there. So there's no gas exchange happening in this set of alveoli. Smoke inhalation. It's on page 602. Remember, if your kid has fever, take off the clothing and the blankets. It's on page 602. Remove all the heavy clothing and heavy blankets and encourage fluids. Sometimes when a kid has pneumonia, they won't have hardly any signs or symptoms of anything else except they will say their tummy hurts. They have tummy pain. It's that pneumonia may be down here in this lower lobe, and it's hurting that lung whenever that diaphragm pushes on it. So they may feel tummy pain. Smoke inhalation injury may cause carbon monoxide poisoning. Carbon monoxide is not toxic to the lungs, but the problem with it is it attaches to the hemoglobin and forms carboxyhemoglobin, which prevents the oxygen from bonding to the hemoglobin. Remember, our hemoglobin carries around our oxygen throughout our body. So when we inhale carbon monoxide, it changes over to this carboxyhemoglobin, or COHB, and it prevents that oxygen from attaching to that hemoglobin. So we're not moving oxygen throughout our body. We're moving carbon monoxide. Pulse ox is irrelevant because it's not going to detect carbon monoxide. It detects red blood cells, or the hemoglobin in the red blood cells. Well, that's normal. That's still going to be normal in these patients. But the oxygen is not going to be on those red blood cells. So pulse ox can be normal, but we may have a serious carbon monoxide injury from smoke inhalation. What patients are we going to worry about in a fire for smoke inhalation? What patients?
Asthmatic.
What about, okay, let me find a different way.
Children and elderly.
Yes.
Immoved.
Yeah, well, yes. What about, what type of burn patients? What are we going to see when we assess these patients and we're looking at them in their
Low fluid. To see if they have soot in their throat.
soot? Yes. Do they have black faces? Have they got in that soot with that smoke just, and in their mouth? Do they have soot in their mouth? Singed nose hairs? All those things. Those are going to be your patients that you're going to worry about for smoke inhalation. That just, yeah, priority. Okay. So remember, with carbon monoxide poisoning, smoke inhalation, that your pulse ox can be completely normal. Completely normal, because that pulse ox is only looking for the hemoglobin on the red blood cells, and that stuff is normal. But we're not attaching, our oxygen is not able to piggyback on top of that hemoglobin with carbon monoxide poisoning, because that carbon monoxide is blocking that out. Blocking that hemoglobin from the oxygen. 3 stages of a smoke inhalation injury. Pulmonary insufficiency is the first 6 hours. So they're just kind of not able to breathe very well. Then we'll see in the next 6 to 72 hours pulmonary edema. What are do y'all remember your signs and symptoms of pulmonary edema?
Weak, crackling.
What is something really evident of edema? What sign or symptom?
I noticed that increase.
It's a color.
Pink.
Yep. Frothy pink sputum. When you see frothy pink sputum, be thinking pulmonary edema. And that is that second stage of a smoke inhalation injury or carbon monoxide poisoning. Pulmonary edema, that swelling leads to pink frothy sputum. And then they'll eventually get pneumonia. When burns are evident around the face or mouth, heat injury to upper airway should be expected. When you see all those signs that they have had their face in heat, soot, singed nose hairs, any of those things, suspect that they've got an injury to their upper airway, a burn to their upper airway. So look in their airway, but make sure you have a trach set and an intubation tray at the bedside. Anytime you have somebody that looks like they have inhaled smoke, that they've got a heat injury, an inhalation injury, make sure you have an endotracheal tube set and a trach set at the bedside. Because again, your trach is more invasive, yes, but it's going to be quicker to get that patient some oxygen. Also, what do you need in your endotracheal tube set with intubation, your intubation tray? What?
A smaller.
Yes, yes. What else? Okay, y'all are looking in the throat. It's dark in there. You have that blade that goes in the mouth to open it up. That blade has a light on it. That thing runs on batteries. You better have some batteries. You better make sure you've got good batteries for those things. That is the responsibility of charge nurses, is to make sure that there are batteries for those intubation trays. If we have an emergency with an airway and we give our doctor a blade that has no light to it, do you think we're going to get in trouble?
Yes.
Yes, we're going to get in real bad trouble. So always make sure there's batteries, fresh batteries, in an endotracheal tube set. Not only heat can cause airway injuries, but also inhaled toxins can cause chemical injury. Like, let me think, your carbon monoxide, also those things, stuff that those kids huff and puff all the time. You know, not inhaler, not spray paint, the duster. Yeah, computer duster. They inhale that can cause burns in their airway. So we need to be watching for that and teaching about that. Smoke inhalation treatment, oxygen therapy, careful monitoring of eyes and nose and ABGs. Hyperbaric therapy is also beneficial, especially with those carbon monoxide poisonings. The hyperbaric therapy, where they lower the pressure really, or increase the pressure, and they go and get in that tube, and anyway, it's very helpful for them. Respiratory arrest can occur suddenly, so make sure you have that intubation tray. What are we going to teach our parents about preventing burns and such in our homes? Smoke detectors, carbon monoxide detectors. Make sure you change those batteries. Don't leave matches, lighters, all those things laying around. The handles of the pots on the stove, turn them backwards. All of that, but make sure those smoke detectors are working and carbon monoxide detectors. I change batteries on January 1st every year. That's what I do. Tonsillitis and adenoiditis. As a matter of fact, I was watching y'all's videos of your test, y'all taking your test a couple weeks ago, and I could hear somebody's smoke alarm in the background. Beep, beep. Yeah, change your batteries. Change your batteries. Okay. Tonsillitis and adenoiditis, inflammation and infection of the tonsils and the adenoids inside the throat. They're lymph tissue. They are there to help clean out trash and debris. Sometimes they just get infected, and some kids have a real problem with having recurrent infections and enlargement of those tonsils. Signs and symptoms: difficulty swallowing, dyspnea. your enlarged adenoids are going to block your nasal passage. So they're back further in the throat, and they'll block you from being able to breathe through your nose. So you become a what type of breather? A mouth breather. Yeah, these kids will be mouth breathers. Drainage, any kind of nasal drainage, any kind of secretions can irritate that and cause asthma. So these kids may be subjected to asthma later. Nursing care, another cool mist thing. Cool, humidified air. Saltwater gargles. You want them to gargle it and spit it out. You don't want them to swallow it. You want them to spit it out. So if they're not big enough to gargle and spit, then don't give it to them. Throat lozenges, if age appropriate. You don't want to give a 1-year-old a cough drop to suck on. And acetaminophen for pain or fever. Let's see. How do you know that we might need to have tonsils removed and adenoids removed? What signs?
Like they don't rest good. My baby got hers. She kept waking up like out of sleep.
Yeah. Infections. They don't rest good. What are they doing at night when they're sleeping? Snoring. They sound like a grown man snoring. They are loud snorers. They were just blocking off that nasal passage.
It was just blocking off her nose passage. She sounded like a whole man. She was 7.
Yeah, they do. It's awful. And when they're little, a lot of kids have enlarged tonsils when they're small. When they get big enough to be causing some obstruction is when we need to get them out. And that obstruction is what's causing that snoring when they're sleeping, because they're laying down, they're relaxed, that tongue is falling back when they're sleeping, so their little airway is getting very small with those tonsils. Treatment may require removal of tonsils and adenoids, and they do not recommend tonsillectomy and adenoidectomy for children under 3. Remember, these kids are mouth breathers. This tonsillectomy, is it pretty easy for kids? Yeah.
That was their medicine where I be crying and then it breath be stank.
Yeah, now they do have stinky. They are stinky. But usually they get those tonsils out and they are okay. Gracie got her tonsils out, and as soon as she got to her room, she ate a pancake. Ruby got hers out and she was fine. No, wait, did Ruby get? Yeah, Ruby did. But they were super young, like 3, 4, when they got it done, and did fine. As adults, are we gonna do as well as little kids? It hurts. It hurts really, really bad. Has anybody had their tonsils out as an adult? Yeah,
I gotta get mine taken out because I get laryngitis.
Yeah, I had mine done when I was 26, and I had a baby without an epidural, and I had my tonsils out, and tonsils trumps baby big time. It hurt, like it just wouldn't stop. You couldn't take any medicine to make it stop. It just hurt. Made your ears hurt really bad. Okay, post-op care for TNA. These are very important because these are the kids that we see in the hospital. Sometimes they have to stay overnight. Maybe they've got a smaller airway and swelling. That swelling may occlude that airway. So we might need to watch these kids overnight. Most of the time, they just get their tonsils out and go home. But we need to teach parents exactly what to look for when they go home. This is an airway problem, and they just had surgery. So it's very important to do your teaching. Teach them to watch for frequent swallowing. What do you think is going on if they're swallowing a lot? They could be bleeding. So that is a big sign of bleeding after a tonsillectomy, is frequent swallowing. If you see them swallowing a lot, you need to be looking inside their mouth. Any vomiting of bright red blood. Vomiting of bright red blood. They've been bleeding. Their tonsils have been bleeding for where the surgery was, and they've been swallowing that blood, and that blood irritates the stomach, so they're going to throw up, and they'll vomit bright red blood.
I remember that. Get my tonsils taken out.
Yeah.
That's the only thing I remember. Bleeding? No, throwing up.
Oh.
I have like a.
After they have their surgery, you want to make sure you encourage them to put them partially on their side. So they'll be laying on their side, partly on their abdomen with their top knee flex. So they're going to be laying down on the bed with that top knee flex. That leg is kind of stabilizing them on their side. That helps decrease pressure. You don't want them laying down flat because it puts a lot of pressure here on their throat. Put them on their side. Signs and symptoms of bleeding. There are going to be any other signs and symptoms of bleeding. Increased heart rate and respiration. Your signs of hypovolemic shock. Restlessness, frequent swallowing, vomiting bright red blood. When they first come out, they do not need to eat pancakes, but Gracie really likes pancakes, so she gets pancakes. They need, I'm telling you, when I got to reading in this book, I'm just thankful my kids have lived as long as they did. You want to give them clear liquids at first. Clear liquids. What color is clear?
Clear.
What color is not clear? What color will we never give a kid? Red. Red, purple sometimes, because that can be very deceiving when it's mixed with blood. So we want to give clear liquids, maybe a green popsicle, maybe blue, but not red or purple. Not red or purple popsicles. Or brown colored juices. I don't. Prune juice, yeah, they're not going to drink that anyway. Also, you don't want to give them a bunch of juice because it's very acidic, and that's open wounds back there on their throat. So don't give them juices. Don't give them carbonated stuff. It's going to burn. Just some water, Kool-Aid, if you can find some that's not red or any purple. Popsicles, freeze up that Pedialyte. That's good for them. They like that. Avoid coughing. Why would you want them to avoid coughing? Pressure. That pressure on that throat can start bleeding. Avoid coughing, clearing throat, gargling, eating spicy food, and blowing nose for that first week post-op. You also do not want them drinking out of a straw or brushing their teeth with a toothbrush. Why not drink out of a straw or brush your teeth with a toothbrush? You scrape against those wounds and knock that scab off, and you're going to start bleeding. So no toothbrushes, no straws. They are going to have stinky, stinky, stinky breath, but just clean that mouth out with a washcloth and toothpaste as best as you can. Also, don't know whenever you get your tonsils out, Mom tells you you can have all the ice cream you want. You don't want to eat ice cream because it builds up a bunch of mucus and it's gross, and then you won't need to cough it up. Well, you can't cough because you've had your tonsils out.
So is that why, what's the stuff called? The Luigi's Italian ice.
Yes, that's good for it.
Yeah.
Yep. Luigi's Italian ice is good. Allergic rhinitis. What is that?
Hay fever.
Yep, hay fever, allergies. Inflammation of the nasal mucosa caused by allergic response. Signs and symptoms are going to be nasal congestion, clear drainage, clear watery nasal discharge, sneezing, and itching of eyes. Are you going to have fever with allergies? No. You need to, how do we diagnose allergies? How do we do that?
With that little test.
Yeah.
See what things we have back.
Yep, the skin prick test. So we do that. The intradermal test.
They do blood.
Oh, they just poke you with a needle?
Yeah, they do it on your back.
Yeah.
They inject the allergy into you.
Yes, the skin prick. Yeah. That, and they can do blood. They can do blood tests to see if you're allergic to anything. If you get a CBC and they're looking for allergies in a CBC, what is going to be elevated in that CBC? Basophils, eosinophils, those two things will be elevated. Will your neutrophils be elevated with? No, you will not have elevated neutrophils with allergies. You will have elevated basophils and eosinophils.
Remember that question?
Me
Mhm.
too, and I missed it because I changed my answer.
Don't change your answers. All right, so you're going to treat it with antihistamines. We talked about antihistamines earlier. Your Benadryl, your Zyrtec or cetirizine, Claritin or loratadine. Do you want to give a kid Benadryl first thing in the morning? No. Give them Zyrtec or Claritin in the morning time, and then give them the Benadryl at night. Then nasal sprays, your glucocorticoid nasal sprays. An example of that would be your Flonase or fluticasone. Those are very helpful if antihistamines are not helpful. And some people do both. Some people do the glucocorticoid nose spray and the antihistamines and decongestants, all of it. When you do a nose spray, how do you do it? Then whenever you puff that medicine into the nostril, what do you do?
Sniff it up.
You don't sniff it up. What happens? I just learned this, but whenever you snip it up, where are you sucking it to? You're sucking it down, so it is doing absolutely nothing for your nose. So you look down, you do your nose spray, you just breathe normal. You don't really,
I feel like I'm
inhale a line or anything. Just a little, just normal breath in through your nose.
It just seems like it's gonna roll right
It
out.
does. It feels like it's just gonna come out, but point it towards the back and it should stay there. Decongestants. We talked about those earlier. That's your Robitussin, things like that.
I'm out of words.
It's hot. Nursing care of allergic rhinitis. Teach your parents the differences between colds and allergies. You need to know the differences between colds and allergies. Teach prevention of environmental factors. So if you've got a kid with all these allergies and you have carpet in your house, should you take the carpet out? We should remove the carpet. Take down curtains. We have nothing. We have no carpet. We have no curtains in our house. We have windows and wood. That's all we've got. Linens on the bed. Wash them in hot water every week. I've known people that rarely ever wash their linens on their beds. Make sure you're washing those. Those mattresses are nasty. You lay in them for hours and hours. It's nasty. Avoid contact with animal dander. So your pets, vacuum your carpets weekly. I don't know who gets away with doing that, but we had to vacuum when we did have carpet. We had to vacuum every single day. HEPA air filters, those special allergy filters for your air conditioning at the house. Yeah, just clean up everything. Yep. Are you gonna be able to have your windows open and your doors open in the springtime at this time of the year? No. No.
Glad ain't nobody in my house got
No.
got
Very
allergies.
glad.
Yeah, I love that breeze.
Me too. So Zyrtec cetirizine is commonly advised as helpful with Flonase to prevent and treat symptoms of allergic rhinitis. Assist if allergy testing is applicable. So that scratch test on the back. So they'll get that big, what it is a big cartridge, and it's loaded up with all these different allergens, dust, dander,
You feel like they
cat,
sticking a
dog.
brush down your back.
Yes, and they just poke it onto your back, and all those allergens are released into your skin. They whelp up if you're allergic. They don't if you're not. Yeah, that's a good point. You need to stop taking your Benadryl within 2 days of taking that test. And your Zyrtec, any kind of antihistamine, you've got to stop taking that, because if you take that test and you're taking those things, then it's all going to be negative, and they're going to think you're not allergic to anything, because your medicine is killing all those histamines.
So when I got mine, and then they started giving me like the allergy shot every week, I
Mhm.
had to change my blood pressure medicine. They said the beta blocker affects it.
Yep.
So I had to get off the metoprolol
Mm,
or something else.
to something else.
I
So
used to give the allergy shot.
I don't know why that is. I need to find out though.
I used to give the shot and do the test.
hmm So allergy testing, if you do allergy shots, those are every week for some certain amount of time, and you have to be, parents have to be, they have to do those. If they're gonna do them, for them to work, they have to do them. So they have to know that they have to do this appointment every single week.
It started off doing twice a week. You do twice a week, you exchange different valves.
Mm-hmm.
The first valve is the weak dilution of whatever you're allergic to,
Yes.
and then it goes up in steps, and you do that for 6 weeks. And then after that, you come every week for 6 months, and then you do another full allergy testing, and it'll let you know how much your system has suppressed those allergies.
Yes. Yeah.
And it'll determine whether you can get off of them or not, 'cause it's
Yeah.
not like lifelong.
Yeah. It's not, allergy shots are not lifelong. They're only a certain amount of time. We're just building your system up to those allergens that you're allergic to, so that maybe we can cancel it out with time and shots. But parents need to be told that they have to do those. If it's going to work, they've got to do it every week, or whatever the doctor prescribes, every 2 weeks, twice a week, whatever. When the kid starts going, are you going to tell them, hey, you're going and getting a shot? No. They're gonna not realize it the first couple of times, but then once they start coming, they're gonna know, oh, I'm getting that shot today. And it may be a fight, but we need to get those. If they are that allergic, we need to go ahead and get that taken care of. This is just, this is the skin prick test, the back test. So they just poked all those allergens into that person. Those big red whelps, those are allergens. I don't know what they are, but they are labeled on the cartridge. Another sign of allergies, allergic rhinitis, is the allergic salute. Is that what it's called? Allergic salute, where the kids are scratching their noses like this. And when they get finished, they've got that little crease on their nose, right across the bridge of their nose. You too?
I was looking at it the other day, I was like, man, I wish I hadn't scratched my nose like that.
Yeah, that is your sign of allergic rhinitis. Allergic salute. Are we just about done with this one? Asthma. Asthma is the increased responsiveness of the tracheobronchial tree to various stimuli that results in reversible intermittent constriction of the airways. So the airways get subjected to whatever makes them reactive, pollen, dust, mold, whatever. It makes those airways constrict. We can fix it. We can use it in an inhaler that is a what? What type of? A bronchodilator, and open those airways again. It is recurrent and reversible obstruction of the airways. Be caused by bronchospasm, mucosal edema, and secretion of mucus contribute to narrowing of the airways, causing impaired gas exchange. So those things can cause any kind of environmental stuff or exercise even can cause bronchospasm, an increase in edema in that mucosal lining in the airway, and increased secretion of the mucus can contribute to asthma. What else can contribute to asthma?
Obesity.
Yeah, obesity. When you lay down at night, you might have reflux. Reflux can irritate the airway and cause you to have asthma attacks. It may be triggered by allergic responses, all those things. Physical activity, viral response, viruses, flu can cause asthma attacks. Rapid changes in temperature and humidity, or emotional upsets that affect smooth muscle and vasomotor tone. Asthma is the principal cause of chronic illness in children. So this is the most common chronic illness in kids is asthma. Right there at the top of that page, you'll see those 4 main components that we talked about: bronchospasm, inflammation, mucosal edema, and airway hyperreactivity. Those are your 4 components of asthma. Those are what's going to cause asthma. And whatever component is causing your asthma is going to determine what treats your asthma. So if you're having a bronchospasm, we're going to give a bronchodilator. What medication is a bronchodilator? Singular, maybe. Albuterol is, yes. Is albuterol a fast-acting? Is it an emergency medication, or is it? Yeah, it's for when you get in the bind, you take your albuterol. It's fast-acting. Then you've got other things like Qvar or Flovent, things that you take every day, maybe twice a day. You take a puff in the morning and a puff at night, and those are your long-acting. Those try to keep the asthma away all day. When you have that breakthrough attack, you use your bronchodilator or your albuterol. That albuterol is your rescue inhaler. Okay, when you have an asthma attack, when Miss Goss has an asthma attack, hopefully she has her inhaler. This is albuterol. I use my albuterol. This one's albuterol. Some kids have bad asthma that they need controlled all the time, so they use those long-acting inhalers. There's also steroid inhalers. I think, what was that one, Singular? Oh, that's used at the pill. Yes, Singular is a pill that you take at nighttime. It makes you sleepy. It's kind of like an antihistamine.
Is it Flovent?
Flovent.
Yeah. Albuterol.
Yeah, so Flovent should be every day. Albuterol is your rescue when you get into a bind with your breathing. Asthma, it can be signs and symptoms. It can come on slow or abrupt. It can be mild, moderate, or severe. You're going to see coughing, wheezing on exhalation. You're going to hear that wheeze when that kid breathes out. Itching in the chin. A lot of asthma attacks start with some itching around your throat, under your chin. Neck or chest. Nasal flaring, if they're having a really, really bad attack. Use of accessory muscles, they're really pulling hard to breathe and open up that airway. Everything is constricted. Their bronchioles, their big bronchioles and their bronchi are constricted. They'll have an increased heart rate and respirations. Rales may be present, and they may have allergic shiners. What are allergic shiners?
Dark circles, right?
Yeah, black eyes. Black eyes from not a fight, from allergies. So like this kid has right here. Miss Goss, if you didn't wear glasses, my glasses cover up mine real good. Allergic shiners, you'll see those, especially in your pale skin kids, your blonde hair, blue eyes. Those kids, they usually have a lot of asthma problems. They have a lot of eczema problems. Eczema and asthma, they're BFFs. Asthma attacks may occur at night. What are you going to hear at nighttime from these kids when they're having an asthma attack? Coughing. You're going to hear them coughing at nighttime. And you may not know that's asthma, but that's a big sign of asthma is when they are asleep in bed, they start coughing at nighttime. Why would they start coughing at nighttime? They're laying down. They might have reflux. Their beds may be full of dust and dust mites and all kinds of things. Labs, remember, your labs will show increased eosinophils and basophils. Our treatment goals, we want to have near to normal pulmonary function. We want them to be able to breathe. Their goal for treatment is that we want them to be able to breathe. We want to prevent chronic signs and symptoms and adverse responses to medications and promote self-care. That means promoting self-care. That means we want them to realize what is causing their asthma. What are their triggers? What does it feel like when I need to take my inhaler? We want them to know those things. We have to teach them when your chest starts tickling or you feel like you're breathing hard, you probably need to take your inhaler. Have y'all ever seen an asthma plan? An asthma plan? Let's see.
It's like an action plan.
Mm-hmm. Your asthma.
Green, yellow, red.
Green, yellow, red. Yep. So when you have a kid with asthma and they get admitted to the hospital with asthma, or if you go to the allergy clinic and they are doing asthma teaching, they should give these parents a copy of this asthma action plan. They will have a peak flow meter. Do y'all know what a peak flow meter is? I had one and it's in Malvern. I forgot it yesterday. It is just this little instrument. And respiratory therapy, they set the parameters for it. You have your green, yellow, red parameters. Your kid takes a big deep breath and blows into it really hard, as hard as they can, like a blow dart, and it'll move that plunger up to one of those lines, and hopefully it's in the green line. They record that number, and they record that every day for a month or something, and get an average peak flow, and that's what they should average all the time, every single day. They will give parameters. So you can see in green, your peak flow is going to be from here to here, whatever numbers the doctor comes up with. And if you have these, you don't need to do anything different in green. You just need to take your daily medicine, your Flovent, your Zyrtec, whatever. You're okay. You don't need anything extra on green days. On yellow days, your peak flow will be whatever to whatever. On these days, you may have signs of a cold, or you may have been exposed to a trigger, pollen. It's giving you a cough, a tight chest, a mild wheeze, or coughing at night. If we get in yellow, the doctor should put what medications you need if you're in yellow. You're going to need your normal everyday medicines, your Flovent, your Zyrtec, but now you might need your Flovent, your Zyrtec, and your albuterol. We might need to get into that rescue inhaler in this yellow area on our asthma action plan. On red, these guys need to go to the doctor. They need to go to the doctor, get an updraft, get some steroids, hospital, whatever. Your asthma is getting worse fast. Medicine is not helping. They take their albuterol, their rescue inhaler, and their wheezing does not go away within 5 minutes. We need to go ahead and go to the doctor, because usually when you take that inhaler, that wheezing is going to go, it's going away. If it is not, breathing is hard and fast, nose opens wide, they're having nasal flaring, their ribs show intercostal retractions, and they cannot talk well. It feels like they're running a marathon, a race, and they cannot talk. Go to the doctor. They're going to need all of their normal stuff. They've tried their albuterol, their rescue inhaler. It's not working. We might need an EpiPen. We might need some steroids, so we need to go to the hospital.
Can I add something to
Hmm?
Can I add something to
Mm-hmm.
So when you're getting allergy shots and you have asthma because your allergies flare up too,
Yes.
if you don't hit your peak flow with it, you won't be able to get your allergy shots. And cause like if you're in the red, they will immediately send you out.
Mm-hmm.
Because if you do get your allergy shot while you're in the red,
You're in trouble.
Asthma attack and a systemic reaction.
Yes, you're in trouble. So what she just said was that when you are an allergy shot patient, you're going in for your weekly allergy shots, you have to do your peak flow meter. Let me show. I know everybody don't know what peak flow is. You have to do your peak flow meter. If you are in the red, they will not give you your allergy shot. They're going to send you out of the clinic, out to get fixed for the day.
And also, they will adjust your dosage of your
Allergen.
Of your allergy injection. They'll put you back down to the bottle before you got to your strongest dose.
Yep.
And then you'll build back up.
Okay, so when you go get your allergy shots, you start off at a minimal dose of allergen, and you build up as time goes on. So if you go in and you're in red, they're going to back you off back to the previous week's amount, or even 2 weeks before that, so that they don't give you too much. If you get too much, then you can go into anaphylaxis. But this right here is a peak flow meter. This is old school looking. This is more recent now, but you can see the red, yellow, green, and you just put your mouth on that and blow as hard as you can, and this red little plunger button will zoom up to wherever you puff it out at. So you need to make sure with an asthmatic, they need to be sure to keep up with that every day. It's very important. Nursing care, we want to teach controlling triggers. So again, get your carpet out of your house, get your curtains out of your house, close your doors, close your windows. Take your allergy medications. Always have your inhaler with you. At school, they're allowing now the asthma kids, to carry their inhalers with them. They don't have to go to the nurse's office. That's kind of a liability if the inhaler's in the nurse's office and you've got a kid in status asthmaticus that needs the inhaler across the campus. We take your medicines. Status asthmaticus, what's that?
Sounds like an emergency.
Sounds like a big emergency. It is a huge emergency. They are not responding to their asthma medication. They're not responding to the albuterol, your rescue inhaler. They continue struggling for air. So that is a medical emergency. These kids are gonna probably need epi to open up those airways.
Oh, man.
Yeah, can we give epi just here at school? No, it's gotta be at the hospital. Or if they have an EpiPen, these kids will probably have an EpiPen. If they've got such bad asthma, they'll probably have an EpiPen to carry with them.
But you still have to go to the hospital once you.
Yes. You still have to go to the hospital after you use that EpiPen. And you've used your EpiPen, so you have to go to the pharmacy and get a new EpiPen. I remember. Oh my gosh. Oh, word. Okay, let's get to 12 o'clock and we'll be done. This is just asthma, what it looks like in those bronchioles. Your normal airway is open. Your asthmatic airway, just your regular asthmatic, like me, I'm just standing here today, I'm feeling good. This is going to be my airway. It's going to be smaller than a normal airway. When you have an asthma attack, this is what it looks like. It gets closed off. Really hard to move air through there. Main goals of asthma therapy: maintain a normal lung function, near normal activity level. Do they have to stop exercising and doing their sports? No, they don't have to do that. Let them do what they can. Prevent chronic signs and symptoms. So take your medicine. Prevent exacerbations. Take your medicine and remove triggers. Prevent adverse reactions to meds. When you take albuterol, what is the reaction that happens? Like, what is a side effect of albuterol? Increased heart rate. Increased heart rate. You're going to have an increased heart rate, but you're going to be able to breathe. You're going to be able to breathe, but your heart is going to be just thumping. That is normal. If you have instructions to take 2 puffs every 4 hours, should you take your second set of puffs in 4 hours if your heart rate's 200 or something crazy? No, don't do that. You need to go to the hospital if you're needing your asthma medicine again, but you can't take it because your heart rate's too high. We need to teach parents how to use inhaler. With little kids, it's best to use a spacer. Why? What difference does this make?
Make sure they get all of it.
Yes, get all of it, and it's also, they can't just click it and suck it up real fast. It makes them slow down, so more of it's getting dispersed inside the lungs. With just an inhaler, a lot of this medicine is just getting into the mouth. It's not even getting down to where it needs to be. But this particular one is called RespiClick, and it does not have to be pumped or primed. It's just powder. So I just open it and suck on it and then click it closed. If I need 2 puffs, open it again and do the other one. But I don't have to squeeze it down. Teach triggers, continue physical exercise, increase fluid intake with exercise. Avoid carbonated and cold beverages. Why? Why cold and carbonated beverages? Cause constriction. It causes that bronchospasm. If y'all have ever seen me drink water, I very rarely drink ice water. This is room temperature water. When I drink ice water, it causes me to cough. It causes me to have an asthma attack. It's causing that irritation and bronchospasm. I always drink room temperature water. So avoid carbonated and cold beverages and avoid dairy products. Now, water is the only cold thing that makes me do it. Sonic drinks don't with ice. Nothing else with ice makes me do that except ice water. It's weird. Okay, let's go to lunch. Let's come back at 1. Are we almost done? Hope so. We gotta learn about the heart today, guys.